I want you to imagine uh, a threat inside your own body right now,
Okay.
and it is working completely unnoticed. Like it has been there for years, maybe even decades. There are no alarms going off. There's no pain.
No sudden fever to tell you something is wrong.
Exactly. There is just this slow, silent buildup of pressure, day after day, year after year, just stressing the system, pushing against the walls, until one day, without any warning whatsoever, a pipe suddenly bursts.
It is, it's a terrifying thought, honestly, but it is the physical reality for hundreds of millions of people.
Yeah.
We have this tendency to view our bodies as these, highly communicative, perfectly calibrated machines, right?
Yeah.
We assume they'll always flash a warning light on the dashboard when something is malfunctioning.
Like a check engine light.
Right, exactly. But this particular condition, it is perfectly engineered by human biology to fly entirely under the radar. The damage is profound, but the symptoms are just invisible.
And that is exactly why we are doing this deep dive today. Our source for this is a really comprehensive medical text called Hypertension, a comprehensive clinical compendium.
It's a heavy read.
It is. But I don't want you to think of this as just some dry medical textbook excerpt or like a list of diagnostic codes. Think of this as a master blueprint of the human body's internal plumbing system.
It really is a fascinating structural document. It lays out not just the clinical definitions of high blood pressure, but the actual fluid dynamics.
The physics of it.
Yeah, the physics of how our cardiovascular system operates, and more importantly, the precise cellular and mechanical cascades that cause it to just fail.
So the mission for this deep dive is simple but really crucial. We are going to demystify blood pressure.
Absolutely.
We're going to decode those numbers you get at the doctor's office, uncover exactly why the body's pressure regulation system goes completely rogue, and, give you the clinical knowledge to understand what is actually happening inside your own arteries.
The medical community calls this condition the silent killer.
Which sounds like a cheap dramatic trope, honestly.
It really does. But after reading through this compendium, it is terrifyingly accurate.
Yeah.
It's fascinating that something so incredibly common could be so, well, unbelievably stealthy.
Okay, let's unpack this. Where do we even begin with understanding how this silent system operates?
Well, we begin with the concept that in vascular health, ignorance is a huge liability.
Right.
Because this condition is asymptomatic for so long, understanding the why and the how behind hypertension is your only real defense.
Knowledge is power.
Exactly. By understanding the intricate mechanisms detailed in this text, you can, move from being a passive patient who just feels anxious when the blood pressure cuff inflates.
Oh, I hate that feeling.
Right, everyone does. But you move from that to being an active participant in your own vascular longevity. So the first step is translating those abstract numbers your doctor reads off into a physical reality.
Okay.
We need to look at what's actually happening in the heart muscle and the blood vessels when a measurement is taken.
Right. Because before we can dive into how the plumbing breaks down, we have to look at how the pressure is measured and, what a structurally sound normal system looks like.
Right.
The text defines hypertension very clearly as a condition in which the blood pressure in the arteries remains persistently elevated. And the unit of measurement is millimeters of mercury, or MEG/Hg.
Which is an old school physical measurement of how high pressure can push a column of liquid mercury up a glass tube.
Yeah, and that measurement is always delivered as a fraction,
Yeah.
right? A top number and a bottom number.
Yes. And these two numbers, they reflect two completely distinct mechanical phases of your heart's continuous cycle. So you have the systolic blood pressure, or SBP, and the diastolic blood pressure, or DBP.
Okay, so systolic is the pressure when the heart is actively contracting. Diastolic is a pressure when the heart relaxes to refill.
Correct.
So when you hear a reading of, say, 120/80, the 120 is the systolic phase, the active push, and the 80 is the diastolic, the resting phase.
Yeah.
The analogy that always comes to mind for me is a mechanical pump pushing fluid through like a closed-loop municipal hydraulic grid.
That's a great way to picture it.
Yeah. So the systolic is that massive, forceful mechanical squeeze of the central pumping station, driving fluid out into the high-pressure mains.
Right.
And the diastolic is that brief window where the pump resets and pulls back, but the fluid in the mains still holds a baseline pressure against the pipes.
That is a much more accurate way to visualize it than, say, the old garter hose analogy. In a municipal water grid, even when the main pump isn't actively firing water into the system, the underground pipes aren't empty.
Right.
And they aren't completely relaxed either. They are maintaining a constant baseline pressure so that, when you turn on your faucet at home, water comes out instantly.
That makes total sense.
So that baseline pressure in the municipal grid, that is your diastolic pressure. And the medical guidelines for adults are incredibly strict about where the upper limits of these pressures should sit.
Yeah, looking at the clinical classifications from the text, the boundaries are razor sharp.
Very sharp.
Normal blood pressure is defined as a systolic strictly less than 120 AD, a diastolic strictly less than 80. The moment you hit 120, you step up into the elevated category.
Right, which is a systolic of 120 to 129, while the diastolic stays under 80.
So just a single digit over 119, and you are out of the normal range.
It is a remarkably narrow band, and it really reflects how exquisitely calibrated the human vascular system is supposed to be.
Wow.
Historically, we used to accept much higher numbers as just a natural part of aging. But modern vascular data shows that even slightly elevated pressure starts causing microscopic endothelial damage.
Which is what?
Oh, basically tiny tears in the inner lining of the blood vessels.
Got it. And then we cross the threshold into actual disease territory.
Right.
Stage 1 hypertension is classified as a systolic of 130 to 139, or a diastolic of 80 to 89. Stage 2 hypertension jumps to a systolic of 140 or higher, or a diastolic of 90 or higher.
Yeah, those are the danger zones.
And finally, the highest tier, hypertensive crisis. That's a systolic of 180 or higher, or a diastolic of 120 or higher. But looking at the physics of this, I actually have a question about that bottom number.
Go for it.
If the diastolic phase is the period where the heart is resting and refilling, the pressure is inherently lower than the systolic peak, right?
Correct.
So why do doctors care so much if that bottom number creeps up from 80 to 90? Isn't the active, 140 millimeter sledgehammer blow of the systolic phase the part that's going to blow out the pipe?
What's fascinating here is that while the systolic peak is the sledgehammer, the diastolic pressure is the vice.
The vice, okay.
Yeah, it tells us a crucial, often darker story about the systemic resistance of your entire vascular grid. You are right that the systolic is the maximum force. But if your resting pressure, that diastolic number, is sitting at 90 or 95, it means your arterial walls literally never get a break.
Ah, so the tension never drops back down to a safe baseline.
Exactly. I mean, arteries are not rigid PVC pipes, right? They are muscular, dynamic tubes composed of living tissue, elastic fibers, smooth muscle.
They need to stretch and bounce back.
Right. They need periods of lower pressure to recoil and maintain their elasticity. So if the diastolic pressure is constantly high, the smooth muscle in the arterial walls is under immense, inescapable strain 24 hours a day.
7 days a week.
365 days a year. There is not a single second of true rest.
Wow.
And over time, that constant baseline tension triggers inflammatory responses in the vessel wall. The tissue becomes scarred, stiff, thickened. It's a process called arteriosclerosis.
Man, that paints a very different, much more insidious picture. It's not just about the big forceful beats. It's about the chronic lack of recovery time for the tissues.
Exactly.
The vessels are essentially being stretched tight continuously until they lose their structural integrity. Which brings up the obvious next question.
Yep.
If we know the thresholds, what is the mechanism driving those numbers into the danger zones? The compendium divides the etiology, the underlying cause, into two very distinct categories.
Yes. It separates the condition into primary hypertension, which was historically called essential hypertension, and secondary hypertension. And the epidemiological breakdown between the two is staggering and, frankly, a bit unsettling for the average patient.
Unsettling is right. Primary hypertension is the dominant form by an overwhelming margin. We're talking 90 to 95% of all clinical cases.
Yep.
And the most startling detail the compendium gives us about primary hypertension is that there is no single identifiable physiological cause. Like, you can't point to a tumor or blocked artery or a specific genetic mutation and say, there it is, that's what's causing the high blood pressure.
Which is incredibly frustrating from a diagnostic standpoint.
Oh, I'm sure.
Because as humans, we want a linear narrative, right? We want a single enemy to fight. A virus, a bacterial infection, a broken bone.
A clear target.
Exactly, but primary hypertension defies that logic entirely. It is a polygenic, multifactorial aggregate. It's the slow accumulation of dozens of minor physiological dysfunctions colliding with environmental triggers over decades.
Right, and the compendium splits these aggregate factors into non-modifiable and modifiable risks.
Right.
So the non-modifiable are basically the biological hand you were dealt. Increasing age, your family history, being male, which the text notes carries a higher risk until women reach menopause. at which point the risk equalizes.
Right.
And ethnicity, with certain populations demonstrating higher genetic predispositions to salt sensitivity and vascular stiffness. I mean, you can't alter those variables at all.
You really can't.
But then you have the modifiable factors, the environmental and lifestyle elements. Obesity, high salt intake, a sedentary lifestyle, smoking, alcohol consumption, chronic psychological stress, diabetes, and dyslipidemia, which is an abnormal balance of lipids or cholesterol in the blood.
And to build on that, the modifiable factors aren't just a list of bad habits, They are potent biological signals.
How so?
Well, take obesity and a sedentary lifestyle, for instance. Adipose tissue fat is not just inert storage. It is an active endocrine organ.
Wait, really? It acts like an organ?
Yes. It secretes inflammatory cytokines and hormones that directly increase vascular resistance and stimulate the kidneys to hold on to fluid.
Wow.
Or dyslipidemia. Excess LDL cholesterol literally embeds itself into the microscopic tears in the arterial wall caused by that high diastolic pressure we just discussed.
It fills the cracks.
Basically, yeah, and it accelerates the stiffening of the pipes. Primary hypertension is essentially the mathematical sum of this modern wear and tear.
That's crazy. But then you have the remaining 5 to 10% of cases which fall under secondary hypertension. And unlike the ambiguous slow burn aggregate of primary cases, secondary hypertension has direct, isolated, and often acute mechanical causes.
Yes.
There is a specific physical culprit hijacking the system.
Right. In these cases, if you find the broken gear and fix it, the hypertension often completely resolves.
That's amazing.
The compendium categorizes these culprits primarily into renal, endocrine, and pharmacological origins.
Okay, let's look at the renal causes first. Issues originating in the kidneys. The text lists chronic kidney disease, polycystic kidney disease, and something called renal artery stenosis, which is a narrowing of the main artery supplying blood to the kidneys.
Renal artery stenosis is honestly a brilliant example of how a localized anatomical problem causes a systemic disaster.
How does it work?
Well, if the artery feeding the kidney is narrowed by plaque, the blood flow dropping into the kidney is severely reduced, right?
Sure.
The kidney's internal pressure sensors misinterpret this localized drop in flow as a massive body-wide drop in blood pressure.
Oh, no.
Yeah, the kidney thinks you are bleeding out.
So it panics.
Exactly. In response, it floods the entire body with extreme, powerful hormones to drive the systemic blood pressure through the roof, trying to force more blood through that narrowed opening. The kidney basically holds the rest of the cardiovascular system hostage to fix its own local flow problem.
That is incredible.
Yeah.
The system's own autoregulation becomes the weapon.
Precisely.
Okay, the text then moves to endocrine causes, which are hormonal tumors and glandular malfunctions. It lists hyperthyroidism, hypothyroidism, Cushing syndrome, which is an excess of cortisol, and pheochromocytoma. I hope I said that right.
You did. Pheochromocytoma. It's a fascinating, rare tumor of the adrenal glands, which sit right on top of the kidneys.
Okay.
This tumor is made of chromaffin cells that essentially go rogue. They periodically dump massive, unprovoked surges of catecholamines, adrenaline, and noradrenaline directly into the bloodstream.
So it's just flooding the system with adrenaline.
Yes. It creates wild, terrifying spikes in blood pressure accompanied by sweating, palpitations, severe headaches. It is the biological equivalent of flooring the accelerator of your car while it's in neutral, just flooding the engine with fuel.
That sounds awful. And then we get to the third category of secondary triggers, other causes, which includes obstructive sleep apnea, pregnancy-induced hypertension, and a very interesting list of pharmacological triggers.
Medication.
Yeah, medications. This part really caught my eye because we aren't talking about obscure experimental drugs.
Not at all.
The text lists steroids, oral contraceptives, decongestants, and NSAIDs, non-steroidal anti-inflammatory drugs.
Over-the-counter stuff.
Exactly. These are incredibly common over-the-counter medications. Wait, if millions of people are popping these daily for minor aches or a stuffy nose, are you saying the clinical data shows a direct causal link to systemic vascular disease? Like, treating a cold can actually spike my blood pressure.
Absolutely. And it happens far more often than people realize.
Really?
Yeah. It highlights a profound paradox in modern medicine. Treatments for minor, localized ailments often trigger major systemic crises because we forget the body is an interconnected hydraulic loop.
Wow.
Take oral decongestants, for example. They usually contain compounds like pseudoephedrine.
Right.
These are alpha-1 adrenergic agonists. They work by stimulating receptors in the blood vessels of your nasal passages, causing them to constrict. This reduces blood flow, which reduces swelling, and boom, clears your airway.
But I'm assuming that alpha-1 receptor stimulation doesn't magically stay confined to the nose.
Precisely. Once that pill dissolves in your stomach, the active ingredient enters your systemic circulation. It hits the alpha-1 receptors in the blood vessels of your arms, your legs, your abdomen, and your brain.
Oh, man.
You fix the tiny swollen pipes in your nose by chemically clamping down on every single pipe in your entire body, driving the central pressure up.
That is wild. And what about NSAIDs? If I take something for a headache or a sprained ankle, how does that translate into high blood pressure?
Well, NSAIDs work by inhibiting enzymes called cyclooxygenases, which blocks the production of prostaglandins, the chemicals that cause inflammation and pain.
Okay, that sounds like a good thing.
It is for your ankle. But in the kidneys, specific prostaglandins serve a protective vital function. They keep the afferent arterioles, the tiny blood vessels entering the kidneys filters, wide open and dilated. When you take an NSAID and block those prostaglandins, those tiny vessels in the kidney constrict, renal blood flow drops, and just like with renal artery stenosis, the kidney panics.
It thinks it's bleeding out again.
Exactly. It kicks into survival mode, retaining massive amounts of sodium and water to boost the pressure. It is a stark reminder to always view the body as a holistic, interconnected machine. You cannot isolate a chemical intervention.
That perfectly sets up our exploration of the actual mechanics. We know the triggers age, a high sodium diet, stress, localized kidney panic, certain medications. But how do they physically alter the body's fluid dynamics? Let's look under the hood at the biological equations the compendium provides.
Yes. The clinical text gives us a fundamental physiological equation that governs the entire cardiovascular system. Blood pressure equals cardiac output multiplied by peripheral vascular resistance. BP equals COX PVR.
Okay, to visualize BP equals COX PVR, let's go back to our municipal hydraulic grid analogy.
Sure.
Cardiac output is the central pumping station. It is a calculation of your heart rate multiplied by stroke volume. Essentially, the total amount of fluid the central pump is pushing into the main lines every single minute.
Right.
Peripheral vascular resistance is the state of the millions of tiny pressure-reducing valves out in the neighborhood distribution lines. If the fluid volume coming out of the main pump increases, or if those millions of tiny neighborhood valves suddenly tighten and narrow, the pressure inside the entire municipal grid skyrockets.
That is the exact physics at play. If you alter either side of that equation, more volume pushing out or more resistance pushing back, the systemic pressure rises. And the compendium outlines 4 highly specific biological mechanisms that manipulate this equation, driving it into the hypertensive danger zone.
The first mechanism the text identifies is increased sympathetic nervous system activity. This is the body's autonomic fight-or-flight response kicking into overdrive.
Right. And mechanically, sympathetic overdrive hits both sides of our equation simultaneously. When you are under chronic psychological or physical stress, your brain signals the release of norepinephrine. This neurotransmitter binds to beta-1 receptors in the heart, making it beat faster and harder.
So that drastically increases cardiac output.
Yes. But simultaneously, it binds to those alpha-1 receptors in the blood vessels we mentioned earlier, causing widespread vasoconstriction.
Which drastically increases peripheral vascular resistance.
Exactly. It turns the central pump up to maximum power while simultaneously closing all the neighborhood valves.
A recipe for catastrophic structural failure.
Complete.
The second mechanism the text details is a massive one, perhaps the most critical pathway in vascular medicine, the renin-angiotensin-aldosterone system, or RAAS. The compendium breaks this down into a highly specific chemical cascade. First, specialized cells in the kidneys sense a drop in pressure or sodium, and they release an enzyme called renin into the blood.
Renin is the catalyst. It floats through the bloodstream until it finds a protein produced by the liver called angiotensinogen, and it cleaves it into a mildly active substance called angiotensin A thirst.
But angiotensin I isn't the real threat yet, right?
It's not.
The text notes that as angiotensin I travels through the body and passes through the lungs, it encounters another enzyme called ACE, or angiotensin converting enzyme. ACE convert to angiotensin I into angiotensin II, and the compendium describes angiotensin II as an incredibly potent vasoconstrictor.
It is one of the most powerful blood vessel constrictors naturally produced by the human body.
Wow.
When angiotensin II hits the vascular smooth muscle, it causes intense sustained contraction. But it doesn't stop there.
It does more.
Yeah, angiotensin II then travels to the adrenal glands and triggers the release of a hormone called aldosterone.
And aldosterone's job is to go right back to the kidneys and instruct them to aggressively reabsorb sodium.
Right.
And wherever sodium goes, water funnels through osmosis. So the kidneys stop producing as much urine and instead hold on to fluid, drastically increasing the overall blood volume.
This RAS cascade is arguably the most important mechanism to deeply understand in this entire physiological review. It is a biological feedback loop of immense power.
Before we move to the next mechanism, I want to clarify something.
Sure.
Why does the human body even possess a system that seems perfectly designed to destroy its own arteries? Like, what's the point?
That's a great question. If we look at this through an evolutionary lens, the RAAS system isn't a flaw. It is an ancient, incredibly successful doomsday survival mechanism.
Okay, how so?
For 99% of human history, the greatest threats to our survival were severe trauma, blood loss, and extreme dehydration. If an ancient human was attacked by a predator and was bleeding out or was wandering in an arid climate without water, their blood volume and pressure would plummet towards zero.
They'd be in shock, right?
The brain and organs would quickly die of oxygen starvation.
So the system evolved to save us from bleeding to death or drying out.
Exactly. The RAAS system would activate to save your life. Angiotensin II would fiercely clamp down all your blood vessels to maintain enough pressure to keep blood flowing to your brain, and aldosterone would signal your kidneys to hoard every single molecular drop of water and speck of salt it could find to maintain your fluid volume. It was designed to keep us alive in extreme, acute trauma.
But here in the 21st century, the vast majority of us aren't bleeding out from a predator attack, and we aren't wandering the desert. We are sitting perfectly still at desks, experiencing chronic psychological stress from emails and mortgages, and eating diets packed with manufactured, highly concentrated sodium.
Which creates a profound biological mismatch. This ancient survival software gets falsely triggered by modern stress and dietary salt.
It goes haywire.
Entirely. The body interprets the chronic stress as a physical threat, and the massive sodium load disrupts the delicate osmotic balance. The RAAS system turns on and clamps down our vessels, hoarding salt and water when we're already fully hydrated and sitting in a climate-controlled office.
So it's basically confused.
It is. It transforms from a life-saving mechanism into an entirely self-destructive loop.
Our hardware is literally destroying itself because it can't distinguish between a saber-toothed tiger and a looming deadline.
Well said.
That brings us to the third mechanism in the text, endothelial dysfunction. The endothelium is the delicate, single-cell inner lining of your blood vessels. The text states that dysfunction here means a severe reduction in nitric oxide and an increase in vasoconstrictors like endothelin.
The endothelium is not just a passive Teflon coating inside the pipes, It is a highly active, metabolically brilliant organ system.
Really? Just a single layer of cells?
Yeah. Healthy endothelial cells constantly produce nitric oxide, which is a gas that diffuses into the surrounding smooth muscle and tells it to relax and dilate. It is the natural counterbalance to angiotensin II.
Oh, I see.
But chronic high pressure, inflammation, and high cholesterol physically damage these cells. They undergo oxidative stress. They stop producing nitric oxide. The pipes literally lose their biochemical ability to widen and relax. They become stiff, rigid, reactive tubes instead of flexible, dynamic ones.
The fourth and final mechanism driving the pressure equation is volume expansion. The text explains that increased sodium intake combined with renal retention mechanisms like aldosterone directly leads to increased overall blood volume.
Right.
Going back to the municipal grid, volume expansion is like hooking up a massive secondary water main to the same closed system. If you turn the central pump up to maximum via sympathetic overdrive, close all the neighborhood valves via angiotensin II, make the pipes rigid through endothelial dysfunction, and then pump in an extra 20% of fluid volume, the physics dictate that the system will inevitably suffer catastrophic failure.
It is a mathematical certainty. And because the human body is incredibly adaptive, it simply resets its internal baroreceptors, its pressure sensors, to accept this new, terrifyingly high pressure as the new normal. You rarely feel the physics failing.
Which perfectly transitions us into what the clinical text calls target organ damage. Because you don't feel the pressure, you don't feel the destruction, but where does all that kinetic energy go? It has to dissipate somewhere.
This is where we examine the fallout of that unrelenting diastolic vice and systolic sledgehammer we talked about earlier.
The compendium is blunt about the clinical presentation, usually asymptomatic. If symptoms do appear, they are dangerously vague and easily dismissed.
Very vague.
The text lists headache, dizziness, fatigue, palpitations, blurred vision, and epistaxis, which is the medical term for severe nosebleeds. I mean, you could attribute almost all of those symptoms to simply having a stressful week at work or not drinking enough water.
Exactly.
But beneath that silent surface, the text details profound target organ damage across major bodily systems. It starts, unsurprisingly, with the heart.
The heart is the primary victim of hypertension because it is the physical engine fighting directly against all that vascular resistance. It takes the brunt of the workload.
The text lists left ventricular hypertrophy, coronary artery disease, heart failure, and myocardial infarction, or heart attack.
Yeah.
Let's break down left ventricular hypertrophy, because it sounds like a structural adaptation, but the text frames it as a severe pathology.
Left ventricular hypertrophy is a brilliant example of how a compensatory mechanism ultimately becomes fatal.
How so?
Well, the left ventricle is the main muscular chamber of the heart that pumps blood out into the body. Because the systemic peripheral resistance is so high, because all those tiny vascular valves are closed, the left ventricle has to generate immensely higher pressure just to open the aortic valve and push the blood out.
So it's working way harder than normal.
Right. And just like lifting heavy weights causes your bicep to grow, pumping against extreme pressure causes the heart muscle cells, the myocytes, to physically enlarge and thicken. The heart hypertrophies to handle the load.
But wait, in a skeletal muscle, we view hypertrophy as a good thing. We want bigger, stronger muscles. Why is a thicker, stronger heart muscle a clinical disaster?
Because of the physics of the heart's blood supply. The heart muscle gets its oxygen from the coronary arteries that run along its surface and dive down into the tissue.
Okay.
When the ventricular muscle becomes massively thickened, the capillary network does not grow proportionally.
Oh.
You now have a massive, bulky slab of muscle that requires significantly more oxygen, but it is being supplied by the same limited network of tiny vessels. Furthermore, that thickened muscle becomes stiff. It loses its elasticity, meaning it can't relax and fill properly during the diastolic phase.
So it's starving for oxygen and it can't relax.
Precisely. Eventually, the oxygen demand outstrips the supply, leading to subendocardial ischemia, microscopic tissue death, which leads to scarring, fibrosis, and ultimately heart failure. The pump physically burns itself out.
The structural logic is terrifyingly clear. Moving from the pump to the central processor, the compendium details damage to the brain. The high pressure can lead to strokes, transient ischemic attacks, which are often called mini-strokes, and vascular dementia.
The vascular architecture in the brain is incredibly dense and delicate. The tiny, penetrating vessels deep in the brain tissue simply cannot withstand decades of high-pressure pounding.
What happens to them?
Two things happen. Either the vessels develop microscopic aneurysms, weak bulging spots called Charcot-Bouchard aneurysms that eventually rupture and cause a hemorrhagic stroke, bleeding directly into the brain tissue.
That's awful.
Or the vessels react to the pressure by thickening their walls so aggressively that the lumen, the opening, essentially closes off completely. This causes tiny localized strokes called lacunar infarcts.
Wow.
Over decades, accumulating thousands of these microscopic dead zones leads directly to severe cognitive decline and vascular dementia.
The pressure destroys the hardware running the software. Next, the compendium lists the kidneys. The text identifies chronic kidney disease and proteinuria, which is the presence of protein leaking into the urine.
The kidney is essentially a massive, highly pressurized filtration plant. It contains millions of microscopic tuft-like capillary beds called glomeruli. These capillaries have a highly specific barrier designed to filter out toxins while keeping large, essential molecules like proteins safely inside the bloodstream.
Right, they're like sieves.
Exactly. When systemic hypertension drives immense pressure into these delicate capillary tufts, it physically damages the cellular architecture of the filtration barrier. The pores widen and tear.
And that's why proteins start spilling into the urine.
Exactly. Proteinuria isn't just a lab abnormality. It is a macroscopic red flag. It is the clinical equivalent of seeing large chunks of debris coming out of your municipal water filter.
Meaning the filter is broken.
Yeah. It tells the physician that the microscopic filters deep inside the organ are structurally failing under the pressure. Over time, these destroyed glomeruli turn into scar tissue, leading to irreversible chronic kidney disease.
The compendium also lists direct damage to the blood vessels themselves, citing peripheral arterial disease blockages in the legs and aortic aneurysms, where the extreme pressure causes the main artery leaving the heart to balloon outward and threaten catastrophic rupture.
Right.
But then the text moves to a completely different organ, the eyes, specifically hypertensive retinopathy. And here's where it gets really interesting.
The human eye provides a unique diagnostic window that exists nowhere else in human anatomy.
Yeah, the text breaks down the clinical grading of the physical damage visible inside the eye. It's a 4-stage progression. Grade Hers is mild arterial narrowing. The pipes are just starting to clamp down. Grade 3 is a phenomenon called AV nicking. Grade 3 shows cotton wool spots, flame hemorrhages, and exudates. And grade 4 is papillema, which the text defines as swelling of the optic disc. I mean, when you go to the doctor for a physical and they dim the lights and shine that bright little ophthalmoscope deep into your eye, they aren't checking your vision.
No, they aren't.
They are looking at your retina because it is the only place in the entire human body where a physician can visually observe your central nervous system and your vascular system without making a surgical incision.
It is a profound realization for many patients. They are looking at the only exposed plumbing in your system to gauge the systemic destruction in real time.
Let's look at grade 2, the AV nicking. What does that actually look like?
Well, in the retina, arteries and veins frequently cross over each other. Because they share a common sheath at the crossing point, when the high-pressure artery becomes thickened, rigid, and sclerotic from hypertension, it physically compresses the thin-walled vein beneath it. It looks like the vein has been nicked or pinched off. It is visible proof of the arteries turning into rigid, destructive structures.
But what about grade 3? The text lists cotton wool spots and flame hemorrhages. What are those physically?
Flame hemorrhages are exactly what they sound like. The delicate retinal capillaries literally burst under the pressure, leaving microscopic flame-shaped streaks of blood pooled in the retinal tissue.
Oh, jeez.
And cotton wool spots look like tiny, fluffy white clouds on the retina. But they aren't clouds. They are areas of ischemia infarctions in the nerve fiber layer.
So the tissue is dying.
Yes, the high pressure has shut off the blood supply to that specific microscopic zone, and the nerve fibers have died and swollen. And grade 4, papillema, occurs when the systemic pressure is so astronomically high that it increases the intracranial pressure inside the skull, physically pushing the optic nerve forward into the back of the eye, causing the optic disc to swell.
Wait, really? So if a doctor looks into your eye and sees flame hemorrhages and dead nerve fibers, they are making a systemic assumption, aren't they?
Yes. And to build on that, the assumption is an absolute clinical certainty. If a doctor sees those tiny bleeds and infarctions in the exposed tissue of your retina, they know instantly, without a shadow of a doubt, that the exact same microscopic bleeding, tearing, and cellular death is actively happening in the dark, hidden tissues of your brain, your heart muscle, and your kidney glomeruli.
The damage is everywhere.
Universal. This is the paramount reason why the medical community emphasizes that hypertension must not be viewed merely as a cardiac condition. It is a total systemic destructive vascular disease.
Right.
The heart is merely the pump that generates the force, but the structural devastation occurs everywhere the high-pressure fluid touches.
So if the symptoms are essentially silent until you start dropping dead nerve fibers in your eyes or leaking protein from your kidneys, how do clinical detectives catch this condition before a patient hits grade 4 papillema or suffers a massive hemorrhagic stroke?
That is the big challenge.
That takes us to the evaluation protocols in the compendium. It requires a highly methodical, multi-stage diagnostic workup. You can't just slap a cuff on an arm once and declare a chronic disease.
Precision is vital here. I mean, a single high reading could just be anxiety, the classic white coat syndrome, where a patient's sympathetic nervous system spikes purely out of fear of being in a medical environment. The diagnosis requires sustained, verifiable data.
The text outlines a rigorous, step-by-step evaluation process. First is the clinical history. The physician checks the duration of the elevated numbers, family history, substance use, smoking, and alcohol habits.
Right.
And specifically conducts a targeted interview to screen for the symptoms of those secondary causes we explored earlier, asking about sleep apnea or random surges of sweating that might indicate a pheochromocytoma. Next is the physical examination. This involves measuring the heart rate, calculating body mass index to assess the obesity variable, conducting the fundus examination of the retina with the ophthalmoscope, listening to the heart for abnormal sounds like bruits or murmurs. And crucially, the text emphasizes checking blood pressure in both arms.
Very important step.
I have to pause here. Why on earth do doctors need to check the pressure in both arms? If the body is a closed-loop hydraulic system, shouldn't the pressure in the left arm be identical to the pressure in the right arm?
You would logically assume so, but that assumption is exactly why the protocol demands checking both. A minor variance, maybe 5 or 10 points between the left and right arm, is anatomically normal due to how the major vessels branch off the aorta.
Right, that makes sense.
But a significant discrepancy, say a 20-point difference in systolic pressure between the left and right arms, is a massive flashing red siren for a physician.
What does that discrepancy physically represent?
It indicates a severe structural anomaly in the main distribution lines. It could mean there is a massive atherosclerotic plaque causing a severe blockage in the subclavian arteries supplying one arm, artificially dropping the pressure on that side.
Okay, that's bad.
Or, far more terrifyingly, it could indicate an aortic dissection.
Oh, wow, what is that?
This is a catastrophic condition where the extreme pressure literally tears the inner lining of the aorta, the massive main pipe leaving the heart. Blood surges into the tear, separating the layers of the artery wall, creating a false channel that can choke off the blood supply to the arteries branching off to the arms or the brain.
Oh my God.
Yeah, so by simply inflating a cuff on both arms, the doctor is conducting a rapid, non-invasive structural integrity test of the body's primary hydraulic mains.
That is an incredibly elegant piece of diagnostic logic.
It really is.
Once the physical exam is complete, the compendium outlines a series of routine investigations. These are the standard lab tests: a complete blood count, fasting blood sugar, and an HbA1c to screen for diabetes, serum creatinine and electrolyte panels to assess kidney function, a comprehensive lipid profile to check cholesterol levels.
Standard stuff, but vital.
Right, and a routine urinalysis specifically hunting for albumin or protein leakage, and cardiac structural checks like an electrocardiogram, an ECG, or an echocardiogram.
And these routine labs aren't just a standard checklist, you know? They serve a highly targeted dual purpose.
That's the first one.
First, the physician is hunting for the co-conspirators, the modifiable risk factors like high blood sugar or elevated LDL cholesterol that exponentially multiply the damage of high blood pressure.
Makes sense.
Second, and more importantly, they are hunting for the silent chemical echoes of target organ damage. That microalbuminuria, the trace amounts of protein in the urine, is the canary in the coal mine. It tells the doctor the endothelial damage is already occurring at the microscopic level, even if the patient feels perfectly healthy.
Wow. And if the routine labs or the history give the physician a reason to suspect that the high blood pressure is secondary, meaning it is being driven by a specific isolated malfunction rather than the general aggregate of primary hypertension, they move to the secondary workup.
Right.
This includes an ultrasound of the kidney, the kidneys, ureters, and bladder, a full thyroid function profile, and highly specific esoteric endocrine checks like measuring the aldosterone to renin ratio, cortisol levels for Cushing syndrome, and catecholamines for that adrenal tumor we discussed.
The secondary workup is clinical detective work at its highest level. When a doctor orders an aldosterone to renin ratio, they are peering deeply into that complex RAAS cascade.
How does that ratio tell them what's wrong?
Well, if both renin and aldosterone are sky high, the kidney is driving the problem. But if aldosterone is massively elevated while renin is essentially zero, it means the adrenal gland is autonomously pumping out aldosterone on its own, completely ignoring the body's feedback loops.
Because it's a tumor.
Yes, often a condition known as Conn syndrome. They are hunting for the exact broken biochemical switch.
Okay, so the detective work concludes. The tests are run, the numbers are confirmed on multiple visits, the secondary causes are ruled out, and the diagnosis is solidified. Primary hypertension. The pipes are sustaining immense damaging pressure.
Yeah, now what?
Exactly. The crucial question is, how do we fix the leaks? How do we relieve the pressure on the system before the brain bleeds or the heart fails? That brings us to the management and pharmacology section of the compendium. And the text is incredibly adamant that the very first line of defense is absolutely not a pharmaceutical intervention.
Right.
It is lifestyle management.
The medical consensus is unequivocal on this point. Lifestyle modification is not a suggestion. It is the absolute non-negotiable foundation of any treatment protocol.
Because pills aren't enough.
Pills can unofficially suppress the physics, but lifestyle changes are the only intervention that actually repairs the biological software.
The compendium outlines highly specific, quantified lifestyle targets. Weight reduction to a target BMI of 18.5 to 24.9. Dietary salt restriction to less than 5 grams per day.
That's very little salt, by the way.
Yeah, the aggressive adoption of the Deschange diet dietary approaches to stop hypertension, which emphasizes fruits, vegetables, whole grains, and low-fat dairy while minimizing saturated fats. Exercise mandates of 150 minutes per week of moderate intensity aerobic activity, complete smoking cessation, strict alcohol restriction, and finally, a category labeled stress management, which specifically cites clinical interventions like yoga, meditation, and ensuring adequate sleep architecture.
Notice how systematically this list attacks the fundamental mechanisms we discussed?
Oh, I see.
The weight loss and DASH diet reduce the inflammatory cytokines and insulin resistance that cause endothelial dysfunction. The extreme salt restriction directly counters the volume expansion variable in our pressure equation, starving the kidneys of the sodium they need to hoard water.
I really want to focus on that final point regarding stress management. It's genuinely astonishing to me that in a rigid, deeply scientific pharmacological compendium, they list yoga, meditation, and sleep right alongside the heavy-hitting chemical interventions. To the average listener, that might sound like, I don't know, holistic fluff thrown into a medical text.
Consider this, though. It is the exact opposite of holistic fluff. It is hardcore applied neurophysiology.
Really?
Remember the very first pathophysiological mechanism we covered? Increased sympathetic nervous system activity. The chronic fight-or-flight response.
Oh, right.
Psychological stress isn't merely an abstract emotional state. It is a very real physical flood of highly potent vasoconstricting chemicals, norepinephrine and cortisol. Practices like focused meditation, slow-paced yoga, and deep, slow-wave sleep are clinically proven, highly effective methods for manually stimulating the vagus nerve.
The vagus nerve being the main superhighway of the parasympathetic nervous system.
Exactly, the rest and digest counterpart to fight or flight. If we connect this to the bigger picture, when you stimulate the vagus nerve through deep diaphragmatic breathing, you chemically force the brain to downregulate the sympathetic outflow.
You're hacking the system.
Yeah, you decrease the heart rate, and you instruct the endothelium to release more nitric oxide, causing systemic vasodilation. You are literally using conscious behavioral inputs to alter your body's unconscious mechanical physics. It is just as biological as swallowing a pill.
That is a brilliant reframing. But of course, lifestyle modifications take time, require immense discipline, and frankly, aren't always enough to overcome deep genetic predispositions or advanced arterial stiffness. The pressure has to be brought down immediately to prevent organ failure.
And that's where the meds come in.
Which brings us to the pharmacological treatment protocols. The compendium lists 5 major classes of antihypertensive drugs, and it is a masterclass in targeted molecular engineering. First up on the list are the ACE inhibitors, with generic examples like enalapril, lisinopril, and ramipril.
ACE inhibitors represent a monumental triumph of rational drug design. They are the chemical interceptors. ACE, as we recall, stands for angiotensin-converting enzyme.
Right, so going back to that complex RAS cascade, the kidney releases renin, which makes angiotensin the first. Then the lungs release the ACE enzyme to convert angiotensin to angiotensin the second, which is the terrifyingly potent vasoconstrictor that clamps down the pipes and triggers aldosterone.
You've got it.
So ACE inhibitors step into the chemical fray and chemically bind to that enzyme in the lungs, neutralizing it. They literally stop the body from synthesizing the vasoconstrictor in the first place.
Medical science is directly, elegantly countering the body's flawed ancient survival physics. By completely blocking the RAS cascade at the conversion step, angiotensin II levels plummet. The vascular smooth muscle instantly relaxes, dilating the pipes and dropping the peripheral resistance.
Wow.
Furthermore, without angiotensin II, aldosterone secretion drops. So the kidneys stop hoarding sodium in water, reducing the central volume. You hit both sides of the pressure equation with one molecule.
The compendium does note a highly specific, notoriously annoying side effect of ACE inhibitors, though. A persistent, dry, hacking cough. Why does a blood pressure medication make you cough?
Because the ACE enzyme in the lungs has a secondary job. It breaks down a protein called bradykinin, which is a natural inflammatory molecule. When you inhibit the ACE enzyme to lower blood pressure, you also stop it from breaking down bradykinin.
Oh, so it just builds up.
Yeah, the bradykinin builds up in the lung tissue, irritating the airways and triggering a dry cough. The text also notes the risk of hyperkalemia elevated potassium because when you block aldosterone from reabsorbing sodium, the kidney holds onto potassium instead.
Got it. And if a patient develops that intolerable cough, The compendium shifts them to the closely related ARB's angiotensin receptor blockers like losartan, valsartan, and telmisartan.
Yes.
Instead of stopping the production of angiotensin II, ARBs just sit on the cellular receptors in the blood vessels and block angiotensin II from binding. The key clinical pearl the text highlights is that both ACE inhibitors and ARVs are the absolute preferred first-line treatment for diabetic patients who have protein or that protein leaking into the urine. Why are they the champions for diabetics?
Because of the specific, targeted way they alter the hydraulic pressure inside the kidney. Inside those delicate kidney filters, the glomeruli, there is an entry pipe and an exit pipe. Angiotensin II disproportionately clamps down on the exit pipe, the efferent arteriole, which creates immense back pressure inside the filter, like putting your thumb over a hose.
Oh, okay.
This massive internal pressure is what blows out the filter and causes protein to leak. By blocking angiotensin II with an ACE inhibitor or an ARB, you relax that specific exit pipe. The pressure inside the filter drops dramatically, halting the structural damage and stopping the protein leak. They don't just lower systemic blood pressure, they provide immense localized physical protection to the fragile kidney architecture.
That is incredible precision. Next on the pharmaceutical roster, the text lists calcium channel blockers, or CCBs, like amlodipine and nifedipine.
These target the muscular wall of the blood vessels from a different biochemical angle. For a smooth muscle cell in the arterial wall to physically contract and tighten, it requires a sudden influx of calcium ions through specific channels in the cell membrane.
Right.
CCBs chemically plug those L-type calcium channels. Without the calcium influx, the cellular machinery cannot engage. The smooth muscle simply cannot contract, forcing the artery to remain wide open and dilated, instantly dropping the peripheral vascular resistance.
Then the compendium details diuretics, often referred to as water pills, with examples like hydrochlorothiazide and chlorthalidone.
Diuretics directly attack the volume expansion variable. They target the renal tubules and chemically block the sodium chloride symporters. They force the kidneys to dump large amounts of sodium into the urine, and the water follows the sodium out of the body.
So going back to the pipes.
Right. In the context of our municipal grid analogy, prescribing a diuretic is the equivalent of opening a massive release valve to rapidly drain out a significant percentage of the excess fluid volume, inherently lowering the pressure inside the remaining pipes.
And the final major class listed is beta blockers, like metoprolol and atenolol. If CCBs and diuretics target the peripheral pipes and the fluid volume, beta blockers go straight for the central pumping station. They bind to the beta-1 adrenergic receptors on the heart muscle, blocking the stimulating effects of adrenaline and noradrenaline. They physically slow the heart rate down and reduce the force of the muscular contraction, turning down the power of the central pump.
It is a remarkable, comprehensive toolkit. The physician can mix and match these pharmacological agents to precisely counter the unique pathophysiological profile of the individual patient.
Right.
But we must reiterate, these medications act as a temporary chemical dam. As long as the drug is in the bloodstream, the physics are controlled, but the underlying cellular dysfunction remains. The lifestyle changes we discussed earlier are the only interventions that actually heal the system for the future.
We have spent the last 50 minutes talking about chronic, slow-building pressure, the decades-long silent destruction of the vascular system. But what happens when the biology violently destabilizes?
The emergencies.
Right. When the system overloads rapidly, or when a patient is dealing with a totally different, highly vulnerable physiological state. That takes us to the final, most intense section of the compendium, emergencies and special cases.
This is the terrifying moment where hypertension completely drops its silent act and becomes an immediate, loud, catastrophic clinical crisis.
The compendium defines a hypertensive emergency with extremely strict criteria. It is not simply an elevated number, no matter how high. It is defined as a blood pressure greater than 180 over 120 mmHg with acute, actively progressive target organ damage.
The key is the organ damage.
Right. The clinical examples given are the most severe events in medicine: an acute ischemic stroke, pulmonary edema where the immense pressure forces fluid directly into the air sacs of the lungs, effectively drowning the patient from the inside, acute kidney injury, or the aortic dissection we described earlier.
The clinical distinction here is the difference between an urgency and an emergency. You can walk into an ER feeling fine with a blood pressure of 190 over 120. If your blood work is clean, your ECG is normal, and your neurological exam is intact, you are in a hypertensive urgency.
Okay, so you're not dying that second.
Right. You need medication, but you are structurally stable. The exact moment an organ begins to actively fail. The millisecond the aortic lining begins to tear or the lungs begin to fill with fluid, the classification upgrades to a true life-threatening hypertensive emergency. The rules of engagement completely change.
And the management protocols for an emergency reflect that sheer severity. The compendium mandates immediate intensive care unit admission and the absolute necessity of using intravenous or IV antihypertensive drugs like labetalol, nicardipine, or nitroglycerin. I want to dive into the logistics of this. If a patient is sitting in the ER with a dissecting aorta and a pressure of 220 over 130, why can't the doctor just hand them a massive dose of amlodipine or a strong ACE inhibitor pill and monitor them? Why the absolute requirement for the ICU and continuous IV drips?
Because of the pharmacokinetic reality of time and absorption. In a hypertensive emergency, the organs are actively dying by the second. If you give a patient an oral pill, it must travel down the esophagus, dissolve in the acidic environment of the stomach, pass into the small intestine, be absorbed across the gut wall into the portal vein, travel to the liver where a portion of it is metabolized.
And then finally, enter the blood.
Yes. And only then does it reach the blood vessels. That entire biological journey takes a minimum of 30 minutes to 2 hours. If your aorta is actively tearing down the middle of your chest, you do not have 2 hours. You might not have 2 minutes.
So the IV drugs bypass the entire digestive delay.
Exactly. Intravenous drugs like nicardipine or nitroglycerin are injected directly into the systemic circulation. Their onset of action is measured in seconds. But there is a second, even more critical reason for using IV drips in an ICU setting. Titratability.
Titratability.
Yes. When you swallow a pill, you are committed to that entire dose. You cannot unswallow it if the pressure drops too far. In an emergency like a stroke, the brain's autoregulation is highly compromised.
What happens if it drops too fast?
If a doctor lowers the blood pressure too aggressively or too quickly, they can accidentally drop the pressure below the threshold required to push blood into the damaged brain tissue, causing a massive secondary ischemic stroke. They could essentially starve the brain of oxygen while trying to save it.
That is a terrifying high-wire act.
It is the pinnacle of critical care medicine. By using a continuous IV drip, the ICU physician watches an invasive arterial line monitor the pressure beat by beat. They can dial the dose of the drug up or down by the microgram, carefully, smoothly landing the pressure exactly where it needs to be to stop the tearing without starving the brain. It requires razor-thin precision that a pill simply cannot provide.
The other special clinical case the compendium highlights is a completely different, highly sensitive landscape: hypertension in pregnancy. The text divides this unique physiological state into two distinct categories. First is gestational hypertension, which is strictly defined as a blood pressure of 140 over 90 or higher that occurs after 20 weeks of pregnancy, but crucially without the presence of proteinuria or organ damage.
Gestational hypertension is a warning shot across the bow. The mother's vascular system is straining under the massive physiological adaptations required for pregnancy. But the systemic endothelial damage hasn't fully set in yet. The kidney filters are still intact.
But the second, far more dangerous category is preeclampsia. This is defined as hypertension occurring after 20 weeks with the presence of proteinuria, or severe features like liver dysfunction, low platelets, or neurological symptoms.
This is a massive crisis.
And the pharmacological rules for treating these pregnant patients completely changed from everything we've learned so far. The compendium lists the safe drugs for pregnancy as labetalol, methyldopa, and nifedipine. But it issues a massive, bolded warning to strictly avoid ACE inhibitors and ARBs entirely.
This section of the text highlights the immense, almost paralyzing complexity of treating a pregnant patient. You are no longer managing a single physiological system. You are simultaneously treating two completely interconnected dependent patients at once.
The mother's
vascular biology is under immense dangerous stress and requires immediate intervention to prevent maternal stroke or seizures. However, the fetal biology is in a state of rapid vulnerable development.
So why are ACE inhibitors, which we just praised as the brilliant protective interceptors of the REAS system, suddenly off the table?
Because ACE inhibitors and ARBs are profoundly teratogenic, meaning they cause severe birth defects. While the mother's kidneys are mature, the fetal kidneys are actively developing, and that development relies heavily on a functioning fetal RAS system.
Oh, wow.
If a pregnant woman takes an ACE inhibitor, the drug crosses the placenta, enters the fetal circulation, and completely halts the fetal RAS cascade. This can lead to renal agenesis, where the fetal kidneys simply fail to develop oligohydramnios, which is a dangerous lack of amniotic fluid, and severe cranial bone deformations. The fetus essentially stops growing.
That is devastating. So the absolute most effective protective drugs in the physician's entire pharmacological toolkit suddenly become lethal to the child.
It forces a massive clinical pivot. Doctors must abandon the elegant, modern RAS blockers and pivot to older, established medications. They use labetalol, a specialized beta blocker, or methyldopa, which is a centrally acting alpha-2 agonist that tells the brain to turn down the sympathetic nervous system.
So it's basically using the older tools because they're safer for the baby.
Right. These older drugs are chosen because decades of data prove they safely manage the mother's blood pressure without crossing over and sabotaging the fetus's cellular development. It is an incredibly delicate, high-stakes clinical balancing act where the physician must protect the mother's organs while safeguarding the baby's structural formation.
Looking back over the breadth of this clinical compendium, it fundamentally reframes everything you think you know about a routine doctor's visit.
It really does.
We have gone from mindlessly decoding a simple fraction like 120 over 80 to uncovering the intense, closed-loop fluid dynamics of cardiac output and peripheral vascular resistance. We've explored the ancient doomsday biological cascade of the RAS system, mapped out the silent microscopic devastation occurring across the left ventricle, the brain's delicate vessels, the kidney's fragile filters, and the retina.
And we've walked through the complex clinical solutions.
Yeah, from the neurophysiology of meditation and the chemical interception of ACE inhibitors,
Yeah.
all the way to the beat-by-beat titrations of an ICU emergency.
It really is the ultimate blueprint of human plumbing and structural biology. And I hope you, listening right now, feel deeply empowered by this comprehensive understanding. The next time you are sitting in that exam room and the blood pressure cuff inflates on your arm, you aren't just sitting there anxiously waiting for a pass or fail grade from an authority figure.
You know what's happening.
Right. You understand the profound mechanical, hormonal, and biological physics that are being measured in that exact moment. You know exactly what is happening in the walls of your arteries.
I want to leave you with one final, deeply provocative thought, an extrapolation based purely on the staggering statistics and physiological realities we've explored in the text today. The compendium explicitly states that an overwhelming 90 to 95% of all hypertension is classified as primary, meaning there is no underlying genetic tumor, no anatomical renal stenosis, no broken or diseased organ causing the pressure to rise.
Nothing visibly broken.
The documented triggers are simply chronological age, a diet packed with manufactured salt, chronic psychological stress, and a sedentary lifestyle. So the ultimate question is this: is primary hypertension really a disease in the traditional sense of the word, a structural malfunction? Or is our modern, highly engineered lifestyle so perfectly designed to trigger our body's ancient doomsday RAS survival systems that high blood pressure is just the entirely logical, perfectly functional biological response to the artificial world we've built? Give that something to chew on the next time you look at the astronomical sodium content on a nutritional label, or the next time you feel your pulse quickening while stressed at your desk.
It is a massive, powerful perspective shift. The cardiovascular system might not be malfunctioning at all. It might just be doing exactly, flawlessly what it was programmed by evolution to do, trying to survive in an environment it was never physiologically meant to inhabit.
Exactly. The central pump and the pipes are working perfectly. It's the world we are forcing them to navigate that's the real disease. Until next time.